Hi everyone, and welcome to this episode of the Liver and Guts podcast. My name's Dr. Kash Gupta. I'm a gastroenterologist and hepatologist in the UK. And today I wanted to talk about food allergy tests. What's the evidence base? What's the hype? How to use them usefully? And whether they're useful at all, actually. I get a lot of questions about food allergy testing. Some people just come to you with blood tests, and I have to say a lot of it is not useful. So if you've ever been told, just do a food allergy blood panel and you'll know what to avoid, this episode is for you. So there are crucial distinctions that get missed all the time on this. A blood test can show immune sensitization, but sensitization is not the same as a clinical allergy. And I think that one confusion drives a lot of unnecessary food restriction, anxiety, and sometimes misdiagnoses in the other direction. So in the next kind of 20 to 30 minutes, we'll cover 5 or 6 things, what the common tests actually measure, and I'll explain how each one works in plain English, when they're useful, when they're misleading, and why the food intolerance IgG panels are rejected by essentially every major allergy society, and a practical pathway that you can use with your family practitioner, your allergist, or just your own decision making. So part 1, allergy isn't one thing. So the very first thing we need to do, and this isn't being pedantic, it really does change everything, is separate 3 buckets that people mash together all the time. And the first bucket is the IgE-mediated food allergy. So this is your classic immediate allergy. You eat food and within minutes to about 2 hours, you get symptoms, hives, swelling, wheezing, vomiting, throat tightness, and all the kind of worst cases, you get this anaphylaxis reaction, which is the most allergic reaction that you can get. And this is the category where IgE blood testing can sometimes be helpful. But there's a qualifier, only when used in the right clinical context. And the best practice is start with a history, then test for sensitization. And when there's still uncertainty, proceed to an oral food challenge, which, to be honest, remains the gold standard. The second bucket is the non-IgE-mediated food allergy. And this is usually a delayed type of allergy, more gastrointestinal, often seen in children. You get colitis, enterocolitis syndromes, and the mechanism doesn't tend to be IgE mediated, and that's the important bit. IgE blood tests can be completely normal, and a negative test does not rule out all immune mediated food reactions. Biology is very complex, particularly immunology, and to think that you can just do a couple of tests to rule things out just doesn't work. Third bucket, food intolerance. And this is not an immune allergy. Lactose intolerance is the textbook example. Symptoms overlap with allergies like bloating, diarrhea, and pain. And that's where the confusion tends to start. But the mechanism is entirely different. IgE blood tests are not the right tool in that circumstance. So the question before any testing is always, which bucket does this story fit into? And that kind of influences completely what your test of choice is and how you read the result. Part 2, what the blood tests actually measure. So what do they actually measure? So when people say food allergy blood tests, they usually mean serum-specific IgE. But there are actually a few different tests out there, and they work in quite different ways. So let me try and walk through some of them. Test number 1, serum-specific IgE. This is the most common test, and the lab essentially takes your blood and exposes it to a food allergen, say a peanut protein, that's been fixed onto a surface. If your blood contains IgE antibodies against that food, they'll stick to the allergen. Then they add a fluorescent tag that lights up wherever the IgE has bound. The brighter the signal, the more food-specific IgE you have. Result comes back in units per litre. Now, here's what you need to understand. A positive IgE means sensitization. It does not mean you will react when you eat the food. Lots of people have positive IgE results and eat food perfectly, happily. That's exactly why guidelines warn against ordering big panels, because you'll find sensitization in people who have no problem at all. And that brings us to the base rate problem. And this is the concept that explains most of the confusion. If you test 50 foods in someone who has a vague fatigue, for example, or bloating, but no immediate type reactions, you'll get false positives. Not because the lab is bad, but because of something called pre-test probability. When the chance of a true allergy is low, even a good test produces more false alarms than real positives sometimes. So the test works best when history suggests an immediate reaction to a specific food, and you test that specific food, so history first, then targeted testing. The second test, Component Resolved Diagnostics, or CRD. So standard sensitizer IgE tests use a crude extract of whole food, so a mix of lots of different proteins. But CRD is cleverer than that. It tests your IgE against specific individual proteins within the food. So the best example is peanut. There's a protein called ARAH2 and ARAH1, and essentially ARAH2 and IgE against ARAH2 correlate much more strongly with true peanut allergy than IgE to a whole peanut extract. And why is that? Because some of the peanut proteins cross-react with pollen. So if you have hay fever, you can get a positive for a whole peanut allergy test, even though the peanut is perfectly fine for you. CRD is not magic though, it's a refinement tool, most useful when the standard test and history leave a genuine uncertainty. The third test, a very interesting test, the Basophil Activation Test, or BAT test. Now this one is very different and it's worth understanding why. So the IgE test, sensitized IgE test and CRD both measure antibodies in your blood. They're asking, does this person's immune system recognize this food? The BAT test goes a step further. It asks, when the immune cells actually meet the allergen, do they activate and start an allergic reaction? Here's how it works. A fresh blood sample is taken and mixed with the specific allergen in the lab, the suspected allergen. The focus is on the cells called basophils, which is a type of white blood cell, right at the heart of the allergic cascades. Basophils carry IgE on their surface. So when an allergen cross-links with that IgE, the basophil degranulates or breaks down, and it releases histamine and other inflammatory chemicals exactly like it would during a real allergic reaction in your body. So in the BAT test, rather than measuring histamine, the lab uses something called flow cytometry, something I used a lot in research. And this is essentially a tool which you can think of as having tiny little laser scanners that read individual cells one by one as they flow past. And it looks for activation markers on the basophil surface, the white blood cell basophil, and specifically proteins, in this case CD63, CD203C, which are activation markers. So if the markers go up after allergen exposure, the basophils have genuinely activated and going to degranulate and release histamine. So what you get is a functional readout, not just is IgE present, but does the IgE actually make the cells react? And that's why BAT can offer higher specificity than the sensitized IgE tests. And it helps tell apart people who are merely sensitized from those who are truly allergic. And in some settings, it's been known to reduce the need for oral food challenges. But the caveat is the blood sample has to be really fresh, processed within hours, and needs specialist lab equipment. It's mainly in specialist allergy centers, not GP surgeries.